Is it possible for people to feel physically unwell without an actual medical conditions? What does it say about the relationship between mind and body? A millennia-old argument that bothered many philosophers and psychologists. Thinking of everyday condition, we do you remember catching cold or feeling down with fever? And how was your mind then? Did you have the same level of spirit and energy to do activities that required your full attention and focus? So, what I'm leading with this intro questions is, as you can say, somatic symptom and related disorders. We will talk about dissociative disorders in a later part of this chapter. When you say soma, it has to do with the body, right? That's the term we use. And somatic symptoms are related to psychological effect that is rooted in sometime actual physical symptoms and sometime malingering symptoms, like there aren't actual physical symptoms, but people do show some psychological impairment and distress. However, in compared to panic attack disorder and phobia, other anxiety-related disorder, this particular disorder has a different set of preoccupation. For instance, we'll see more detail. When we talk about panic attack disorder, people have a specific fear about not being able to breathe, leading toward possible heart attack. And again, it's much to do with person's perception of heart attack than actual heart attack, and avoiding those situations. Somatic symptoms, however, is related to anything that has to do with physical well-being. So, my earlier question, when you were sick with some kind of physical ailment, you do notice that your mind is not as sharp as it was. We all have been there. We know it's close to impossible to feel normal when we are physically unwell, or vice versa. When your mind is down, when, let's say, you lost somebody and you try to engage in sport or enjoy some physical activity, that may not happen as spontaneously as you want. Such experience is also an evidence to discard that mind and body can function independently. And we're not getting into philosophical argument here. In fact, cognitive psychology reminds us that our behavior, like we frequently talk, I may have mentioned this a couple of times, the the triad, emotional, behavioral, and cognitive aspect that continues to interact all the time. So we know that they are not independent. Individuals with somatic symptoms and related disorders are pathologically concerned with the appearance or functioning of their bodies and bring them these concerns to the attention of health professionals, which is expensive and also time consuming, who usually find no identifiable medical basis for their physical compliance. So that tells us why it becomes a concern to psychologists or psychological condition, because it's not much about the medical basis, but the person's perception, the concern that he or she has about his physical well-being. Okay, so what do we talk in this part? Well, we will spend little time talking about somatic symptoms and illness, anxiety disorder. Not so much on psychological factors affecting medical conditions and conversion. I do encourage you to read. They are, again, fascinating disorders where people are affected, of course, by medical conditions, and the other part, they have some unidentifiable problem, like people start to not seeing things without any neurological basis. So they have perfect eyes and they complain that they can't see. They're perfect limbs and they complain they can't walk. So It's worthy looking into those two. But well, let's discuss about somatic symptom disorder and illness anxiety disorder. Now, there's several types. Now, you saw that, right? Somatic symptom disorder. Somatic symptom disorder, particularly, is characterized by a focus on one or more physical symptoms. Now, there's one or more physical symptoms accompanied by marked anxiety and distress. Focus on the symptom that is disproportionate to the nature or severity of the physical symptom. Now, the person do have minor maybe or more than one physical symptoms, and we will talk about a case example that will perfectly put this together, and it will accompany by strong, just like in any anxiety related disorder, marked anxiety, and of course leading to suffering, distress, and that distress is disproportionate. So the anxiety you have, for instance, your problem with chest pain could be some kind of food digestion issue or overworking, overstressing, for instance, but you continuously pay attention to that signs and signals of your body, and you become continuously anxious. So it's very disproportionate, too much than necessary. We are anxious about some pain, but these individuals are too anxious to that severity of the physical symptoms, and they also do not accept medical report when they tell you you're fine. What they do is they want second opinion, third opinion, fourth, fifth, and so on. Could dominate the person's life. And the interesting fact about somatic symptom is you develop identity with the symptom, with those physical symptoms, right? That's what it makes it very different than actual illness. You don't identify with physical conditions if you really just want to get over it. But people in this situation, they develop identity. They, continue to seek additional help, and the theories are there. Probably they are in avoidant seeking or attention seeking, right? They just want people to attend, or just don't want to do other activities because they believe they are disabled. And this condition may also seem similar to illness anxiety disorder, but illness anxiety disorder is a condition in which individuals believe they are seriously ill and become anxious over this possibility. So even though they are not experiencing any noticeable physical symptoms at the time, so if you compare, now again, my focus in this class is to talk about prototypical symptoms, the bigger picture of the condition. Now here in illness anxiety, they believe they have a serious illness, and they may or may not have any physical symptom in compared to somatic symptom. They do have at least one or two, right? And even though they are not experiencing any noticeable symptoms. So here you do need a physical symptom, here, there you don't. Become anxious over possibility. Now it's more toward my breathing is not rhythmic, so I might have some early signs of heart attack. And they might also think, like, let's say I have trouble thinking sometime, trouble recalling. Again, it's more perceived difficulty rather than any actual physical condition, and they think I might have early sign of brain tumor. So those are possible illnesses they worry about. Versus when you look at the other condition like conversion, and again I want you to read the section in the textbook, and distinguishing among conversion reactions, real physical disorders, and outright malingering or faking is a little difficult sometimes. Even more puzzling can be factitious disease, in which the person's symptoms are feigned and under voluntary control, as with malingering, but for no apparent reason. Then they look at the studies. It's hard to tell why they complain about physical signs, physical symptoms, even though they're not seeking attention or looking for excuse from their duties. So fascinating disorder that we see in clinical psychology. What are some examples of normal physical symptoms that someone with somatic symptom disorder might interpret catastrophically? So if you ask that question, you might get some answer, right? It could be some normal conditions, but I would like to hear from you. So I'm going to put this in a discussion question. So moving on, let me put this question in discussion forum first. Here, when you define, again, the word soma is related to body. And when people have somatic symptom, they spend a lot of time, excessive amount of time regarding their physical symptoms, and they have maladaptive response to physical symptoms or health-related concerns. Their preoccupation to health is number one reason they could diagnose with SSD, somatic symptom disorder, and they also complain about physical conditions, not one particular area, unlike panic attack disorder. And when they were examined by doctors, scanning or testing, sometime urine test or blood test, there are no identifiable medical conditions were found. So this disorder was somewhat evolved. So these disorders in this particular SSD category were previously known as somatoform disorders. People may present with some physical symptoms. Physicians are able to identify the cause of presenting physical symptoms. Nevertheless, with the available symptoms, the person's emotional distress and dysfunction is definitely too much. That's the term, excessive or disproportionate. For instance, one of my colleagues' mother who displayed emotional distress, which exacerbated the symptoms and impairment for the day when she has fever. Anytime she suffers from a minor fever, and again we do check the temperature is not that high, and she has very heavy breathing, and she also continues to in a way she almost seems like seeking attention. Now sometimes I tease, I talk to my friend like, are you sure? Isn't there something big going on? But she recovers in day or two. So sometime you can see that how person's emotional response to those physical signs could worsen the illness. And in DSM-5, body dysmorphic disorder was previously classified as somatic symptom disorder, which is not in this category anymore. Now, if you remember, body dysmorphic disorder is related to how you look, some body feature that you don't feel okay. So because it involves concern about the body, they had originally in DSM-4 categorized under SSD. It has now been reclassified under obsessive compulsive disorder or related disorder because it's obsessive and compulsive nature. Now, this is a good example for you to keep in mind. DSM-5 is, just like a scientific method, it's tentative. Whatever we see in DSM-5 tentative, it's likely to change. And if you think of body dysmorphic, the obsession is unrealistic focus on a certain feature of the body, and compulsion is action such as mirror checking or effort to conceal the feature. And it's a response when you use treatment, body dysmorphic responds well with the same treatment that works for OCD, obsessive compulsive disorder. Now, this disorder has the same name as the large class of disorders of which it is a part. This may be confusing to us. While somatic symptom disorder essentially replaced DSM-4 somatization disorder, they are very different. If you look at DSM-4 somatization disorder, they necessitated a large constellation of different types of symptoms to be present, whereas somatic symptom disorder can be diagnosed even if there is only one symptom. Now, the other challenge is how to distinguish illness anxiety disorder from somatic symptom disorder. This is again confusing because both disorders may involve anxiety about physical health. In illness anxiety disorder, symptoms are very mild or absent, and the main problem is the high level of worry about having a serious illness. Whereas in somatic symptom disorder, symptoms are definitely present. The main problem in somatic symptom disorder is preoccupation with symptoms themselves. They do have a symptom and they're preoccupied. That could be always researching about symptoms in the internet, or talking to physicians or doctors or nurses, constantly talking about those symptoms with family members and friends, or complaining about physical symptoms to their friends or work employees, so on, employers, so on. Unlike illness anxiety disorder, they are not a concern that they might be indicative of a serious illness. They think there is one because they have a physical symptom. Although concern about the symptom may be present too, because they do worry as well. Now, presence of one or more somatic symptom is often medically unexplained, and the excessive thoughts and feelings and behavior related to the symptoms are present. Now, when you say excessive thoughts about seriousness of the symptom, frequent complaint and request for help, health-related anxiety, and excessive research on those symptoms is present in people with SSD. And because of their preoccupation to these symptoms, substantial impairment in social and occupational function can be seen. Now, when you look at a case example, this will make more sense. So let's take a look at the story from the textbook, Linda's story. Linda is a smart 30-year-old woman who presented swelling in the joints of legs and arms. Now keep in mind, we're talking about an actual physical sign, right? There's a symptom, like swelling in the joints of legs and arms, and some pain from chronic urinary tract infections. And she is happy to be at the therapist. She presented 5-page long healthcare system contact details. She felt sad because nobody could diagnose her conditions properly. Now, if you again go back to here, she did present with some type of physical symptoms, but if she were to diagnose with illness anxiety disorder, she might be just believing in it and she may not have one. Again, coming back, and a lot more detail is available in the textbook, so make sure you read the case story before you proceed with the lecture. And she left her school, nursing school, because of her distress. And she has this unexplained paralysis, and she also obtained disabled status. Now, when people present these symptoms, what do they do after they achieve this goal? Like, let's say if they were seeking some relief from work or seeking attention, they received it, but what do they do? What happens to their condition? Well, they continue to see more, for Linda, she continued to see more family practitioners and other counselors. In her case, she's seeing 1 family practitioner and 6 specialists and 2 pastoral counseling. Now, that constant feeling, that urgency to take action, but nothing seemed to improve is there, right? Now, if you look at the list of symptoms here, 1 or more somatic symptoms, that is distressing, and it also disturbs or dysfunction in daily life. And that anxiety is definitely disproportionate. And the anxiety about possible paralysis or other condition is very high. They spend a lot of time researching about the symptom and trying to find a solution for the symptom. Now, what else could affect her? Now, in Linda's case, she constantly feels the urgency to do something about it. And if she goes to doctor and doctor give their opinion, do diagnosis, she doesn't seem to be satisfied. And symptoms become their identity. This is a dangerous mechanism in somatic symptom disorder. You start to live for those conditions rather than living with, I don't know if you can distinguish that. You make that as your identity, and people do play that sick role. and they could be seeking sympathy or sympathetic response from their family and friends. How psychological factors play a role here to exacerbate and maintain the pain with or without actual physical reason. They might have very milder signs, but if you think how CBT works, now there's a big part in this SSD has to do with cognitive theory. When you say cognitive theory, we're talking about information processing, we're talking about attention, we're talking about memory, we're talking about interpretation, we're talking about belief, and also overall perception, right? Overall perception. Now, anytime you feel something, that is an actual stimulus that is sent to your body, and we pay attention to that stimulus, and we collect that information and try to remember when we need it, and we interpret those information as danger or safe or good or bad. We develop belief about those information, and that affects our perception of what is happening. Now, people with somatic symptom disorder, they seem to have bigger problem in the process of cognition. Now, they may pay too much attention to minor physical symptoms, so they are selectively choosing particular stimulus over the other, and their attention is preoccupied. Now, you don't have much attention, you have like one attention, and if you are too preoccupied by your minor physical symptoms, you're less likely to do well in other areas. For example, Linda, she was a nurse student and she could not focus more because she's more preoccupied by her pain in joint, and they tend to remember more negative incidences than the overall experience. So their memory is again bias. So there is some level of bias there, and they constantly interpret those experiences as danger. We call cognitive distortion. So they don't have realistic view about what is happening, and they develop a belief like I am not well. So if person has this belief, everything that happens around him is based on this core belief. That's what Aaron Beck calls core belief. And this core belief lead to alter your perception, how you perceive yourself. Poor self-esteem, constantly seeking sympathy, and believing that you're legitimately not well. Now, that could be affecting, again, the overall cycle, right? When you have these kind of core belief, I am not well, I am helpless, I am dependent, you constantly interpret every experience in your life based on that core belief. And of course, that worsens the actual sign, and your brain adapts to it. You constantly tell yourself, well, I need that attention. So it definitely affects how you function in everyday life. And this is only diagnosable as a disorder. I mean, people do complain about their physical symptoms and they worry about their health. It is diagnosable if people has this distress and dysfunction because of those symptoms. Let me ask you a couple of questions before we talk about illness anxiety disorder. Now, another disorder in somatic symptom related condition is illness anxiety disorder. We compared this with SSD. This anxiety, IAD, in illness anxiety disorder, is very similar to hypochondriasis that is found in DSM-4. But only difference is that only 20% of individuals with hypochondriasis meet the diagnostic criteria for IAD. Why? Because in illness anxiety disorder, people don't complain about physical symptoms per se, but excuse me, the anxiety associated with it is more concerning. So they worry about acquiring serious illness rather than complaining about the physical signs. It's very subtle, so to keep that in mind. And the reason DSM-5 added this new disorder is because the level of anxiety associated with possible physical possible serious illness. And the anxiety about the possibility of having or acquiring a serious disease is very high, and actual symptoms either very mild, that is almost indistinguishable, or absent. And they have strong disease conviction. They strongly believe, they're not convinced by anybody's explanation for their minor, not even symptoms, minor change or minor, like let's say breathing problem. You breathe, sometimes you breathe fast, sometimes you breathe slow. They're not convinced by medical explanation, and they cannot be assured by those physicians. That is the concern in illness anxiety disorder. Again, it's better to look with a case. The Guile, another case example from the textbook. So make sure you read that story. Guile is a married 21-year-old, excited about life. She's suffering with low self-esteem, and she felt neglected by family members because when she complained or she mentioned that she might develop a serious illness, she was disbelieved and sometimes belittled. And she thought about married that would help the problem, and it ended up with some type of cheating in her marriage. And she had minor physical symptoms, which is breathlessness, sometimes heartache or headache, indicating brain tumor. Now, see, those are possible symptoms that we all experience in everyday life. And they spend so much time researching about those symptoms. And if you think of the Google search engine, it's like a like a fire. It's a good servant but a bad master, right? They give you so many symptoms and diagnosis and treatment, but how accurate they are, that's a different topic to talk. And they also, and in Guile's case, she started to avoid things that she used to enjoy in everyday life. Like she isolated herself, didn't go to public spaces, didn't use public transportation, and so on. Anytime she hear about news about certain disorder, she would start to worry about her own well-being. Now imagine watching TV for even 20 minutes. How many ads do you see on medical conditions and different medication? And those individuals with illness anxiety disorder will definitely try and find a way to cure what they think will happen to them. Now let's compare Linda with Guile. Now, if you remember Linda's story, Linda did have some joint pains. She had infection, and she was visiting many doctors. Guile, on the other hand, she experienced normal discomfort that typically anybody could experience. However, Linda's preoccupation with those normal signs was leading to excessive anxiety, right? And when she was too preoccupied with those anxiety, you can see that she worries about developing a disease, that is serious illness. Now, the other problem here we need to keep in mind is when you talk about SSD, somatic symptom disorder, illness anxiety disorder, is the other possible comorbid diagnosis. And most commonly diagnosed condition here is mood-related disorder. Depending on what type of mood disorder, it could be depression, it could be anxiety-related disorder. Now, people, those who have anxiety, they engage in avoidance behavior. Imagine talking about COVID. If somebody has illness anxiety disorder, any cough or shortness of breath or headache, that could be misinterpreted as COVID and potentially death, right? Being in an ICU versus actual COVID could be somewhat different. And typically people with illness anxiety disorder, they don't go to psychiatrist or psychologist or therapist. Why? Because they think the problem is not related to psychology, it's more about their physiology, their body. And the other problem here with illness anxiety in compared to SSD is medical reassurance does not help. Now, if you compare that to other anxiety disorder like panic attack, if you tell individual who have panic attack complain about possible heart attack and death, they will stop visiting after they are reassured so many times. They would stop. But people with illness anxiety disorder, they will not stop, because they could keep changing. Like, it could be, well, not just a heart attack, it could be AIDS, it could be cancer, it could be brain tumor or some spinal infection. So they don't accept medical reassurance and they continue to consult many doctors, right? And these are definitely bothering, these are definitely distressing. That's another important part here. Always we need to look at, is it distressing those individuals to the point that they cannot function? So distress and dysfunction is there. And two specifiers that we see here is care seeking type and care avoidant type. It could be one or the other. They need to constantly visit physicians and it's very expensive. And if you look at some case examples, they spend a lot of money and time trying to figure out what's going on. So I'm assuming you have somewhat clear picture to distinguish SSD and IAD, somatic symptom disorder, and illness anxiety disorder, and if necessary, other disorder as well. Again, just to summarize, somatic symptom, there is an actual physical symptom, one or more, and they are very worried about the serious illness with those symptoms. In illness anxiety disorder, they are very convinced by the disease, they don't get reassured by physicians, and they may not have any physical symptoms. Now, I want you to look at the statistical and cultural specifiers in the chapter. That will help you to build a little bigger picture. Now, let me ask you a couple of questions and we'll talk about the causes of somatic symptom disorders. If you ask Freud, he would say that there is a deep-seated unconscious conflict in the person to complain about physical well-being, and conflict between id, ego, and superego. So there is unconscious conflict that lead people to feel anxious about their well-being. Now, if you ask Carl Roger, he would tell that the client doesn't receive social and communal support to fully develop as an individual. Now, different theories will tell you different explanation. They do matter, they do count to our understanding why people develop SSD. However, these different theories have different approaches. One thing that current psychologists agree about SSD is that individuals with these SSD-related disorders suffer from faulty assumption. When we say faulty assumptions, we think of process of cognition and perception. Therefore, there's no better way to understand these disorders without talking about cognitive and perceptive procedure. We all experience our body and we all experience some types of aches and pains. However, we don't process information in the same way. That's why we are unique, right? Let's talk about Linda. Now we look at Linda's case, and I would like to use her as an example to talk about information processing, attention, memory, perception, interpretation, and belief. Now, Linda focus on her pain. She feels something in her joints, and that is what she is processing, the pain in the joint. That's how we receive information. And her attention is allocated to look at those physical signs. Whenever she feels, whether it is minor or major, you pay attention to those pain. And when you pay attention to those pain, you selectively choose a particular stimulus to catch. And at the same time, now if you look at the cognitive process, you ignore the other times that you don't feel pain, right? You are constantly searching for those. And if you again look at a little deeper in the brain, your limbic system is looking for signs of threat that could make you distress, that could threaten your well-being. So that limbic system is constantly searching for those alarm, and it immediately, if you remember talking about sympathetic nervous system, looking for those signs to activate some physiological response. And imagine how much cortisol is released when you feel that possible threat to your well-being, and that could itself could be a vicious cycle. It could feed on more anxiety. And when you pay attention, coming back, Linda is paying attention to those pain in her joint, and she remembers most of the things that is related to pain. And she remembers that doctors did not give her proper diagnosis. She remembers that she were unable to walk, she were unable to do activities that she used to do without any help. She remembers all the bills and all the involvement related to medical procedures. Now the memory is again selected, right? You have now the term you use is the bias. Now you have this bias in your memory, you're recalling them. Now perception is interesting topic. It's different from sensation, but it is fed by sensation. We're talking about sensation here when we talk about information processing and attention. Now perception is, imagine you look at a picture of a person and you try to draw as you perceive, right? The picture you draw, your drawing, is not close to, or at least somewhat related to what you actually saw, right? The person in the picture, they both look, my perception. So if you look at an actual picture and you draw that picture, that drawing is the perception of sensation. We use this picture, the actual image, as a reference to draw the picture. Now the perception is our impression of sensation. What do you feel? And these perceptions are always subjective. You draw as you are good at, right? If you have a very good skill and a good processing in the information, you have a good picture. If you are not good at drawing, and if you don't perceive different parts and features, you may not draw a good picture. Same thing is about perception. The way you perceive your sensation is subjective. And Linda perceived those physical conditions are long-term. They are not just a minor ache, it would go away. Minor changes in her lifestyle would help. No, she thinks that is a lot more worse than what doctors are telling her. So she continues to draw again and again. She continues to develop her perception in that on that sensations, and that's where you develop identity. Now Linda identifies with that perception, and there's so many examples you can use. When people in early childhood, when people are used to people are bullied by their peers or family members, you develop your sense of perception, who you are. If somebody calls you stupid every day and many days in the year or many years of your life, you might develop a sense of stupidity in yourself. I don't know, that's not a good example, but it does affect you, right? How you are told. And there's a funny example I talk about. Somebody was carrying a different animal, and they called, let's say they were carrying a goat, and everybody called, "Hey, why are you carrying a dog?" And when continuously he was asked that, "Why are you carrying a dog?" he started doubting, am I really carrying a dog? So your perception is affected by what you were fed through your senses. So you constantly pay attention to pain, you remember them, and your perception of pain is a lot more bigger, and you start to identify with it. Now, the other part is when you have identified with those pain, your interpretation of those pain is very unique than the others. You constantly look for, of course, you're doing some research. Different doctors tell you different possible diagnoses, but you don't have them. But you may only remember what possible diagnosis could be. Or let's say for Linda's case, some doctors said, well, when people complain about joint pain, there is a possible arthritis issues where you have issue in your joint, your ligaments are not so good, so on. She might remember the description, she will associate with that description rather than the doctor was talking about people who actually have physical symptoms. Now, the interpretation comes from all these process, right? You are looking at your history and you interpret them. And in cognitive therapy, cognitive theory, we talk about cognitive distortion. You don't have realistic interpretation about what's happening. You see minor sign as possible threat. We call catastrophizing. And you need more than just pain in your joint, for Linda's case, to diagnose with serious illness, which is minimizing, right? You minimized how many symptoms that you need to diagnose with certain disorder. So cognitive distortion plays a big role, and overgeneralizing, and if you have pain while you as soon as you woke up in the morning, and you think that this will be all my day, so that distortion is very strong, and that feeds through your belief system. I am unwell, I am unwell, I have possible, or I have serious illness. So if you have that core belief, you continuously feed that information. And imagine what goes through person's emotion, right? And you think of, this is cognitive part, what goes through person's emotions and behavior. Emotionally, she's constantly feeling low, doesn't feel energetic, is feeling sad that nobody could help her, nobody could be able to diagnose her. For the Linda's case, she's been to many doctors and inquired for many opinions. So emotionally, she's down, self-esteem goes down. Behaviorally, well, she avoids anything that could worsen her symptoms, anything that could make her difficult to move or engage in other activities. So behaviorally, she is feeding. Now, this loop, cognitive, behavior, emotion, and cognitive, emotion, and behavior, they continue to feed each other. That's where this symptom is more psychological problem than physical. And cause is unlikely to be found in, you cannot just separate them. Maybe there is some minor pain, you maybe just need minor physical therapy, but not to the point that would interfere your life. And the theories and then some research, not theories, research says that it could be the cause, of course, faulty assumption, the other possible, that's what I went on explaining those triad. And here it could be learn from family to focus on anxiety on physical sensation. It could be some family member who exacerbate the physical symptoms and constantly focus on treatments. So it could be learned from family history. Like you've seen your parents, your grandparents, your uncles or aunties who talk about pain, who does research about pain. It could be learned behavior. And the other part here, it's more important to talk about Gail, who has failed in marriage at the early on. So life stress could be worsening the signs. And early childhood illness in family during childhood, again, similar issue. And noticing that when you are sick, you are attended, you get less work, not because you're lazy, but you think that is helping. Perhaps the person is subconsciously aware, but not fully aware, consciously not aware. Like you get attention from individuals. So those could be the possible causes that people continue to develop or maintain somatic symptoms. And this chart shows the same information, your information, events, illness, and you perceived threat, right, rather than actual threat, and you apprehend your apprehension, your anxiety, and you focus more on those signs, in your body respond to your perception, and you continuously check or reassure whether it is actual or not. And this loop continued to add more threat. So it's interesting. It's really interesting to talk about how this vicious cycle continues when people perceive minor illness, minor symptoms as actual threat. That does not discount, that doesn't mean that you should ignore those signs. Well, the good thing is, do the medical check. If you don't receive good diagnosis, you feel not sure from one person, then you go to the other one. However, you don't need to go to 20 different doctors just to make sure that you don't have any problem. Perhaps you might need to reassess, whether there is no actual physical problem. So that might be gateway, in a way, to talk about your anxiety rather than physical symptoms. Now, in terms of treatment, what works the best? Well, there's a limited research on treatment that is effective for somatic symptom disorder. Some case examples that is done research on illness anxiety disorder that been benefited, and particularly cognitive behavior therapy. And what helped them was detailed education on physical well-being. And ironically, some reassurance from medical professionals helped them to reduce becoming anxious about these somatic symptoms. And when it comes to faulty assumptions or faulty interpretation, we definitely talk about cognitive behavior therapy, because you might need cognitive restructuring. And that's where this Socratic questioning is super useful. Socratic question is super useful. You try to challenge people's belief and their interpretation, right? CBT focus on identifying and challenging illness-related misinterpretations of physical sensations, and on showing patient how to create symptoms by focusing attention on certain body areas. In other words, what we try to do in cognitive behavior therapy is we tell them how we create our own belief about illness. So cognitive restructuring, Socratic questioning help them to challenge their belief. And sometimes what therapists do is they bringing on their own symptoms to persuade many patients that such events were under their control. Now, telling them you do have some level of control over it. And patients also receive some coaching and guidance to not seek too much medical reassurance about their concern, because what it does is it continues to feed more. And the small chart here, I don't know if you can see, they try to do exposure therapy for symptoms with hypochondriasis and using CBT. And they found that CBT seems to work much better because people become less depressive, less anxious about their symptom with exposure therapy. Why? Well, of course, exposure therapy is one of the gold standard treatment for many anxiety-related disorder. And when perhaps, again, it's the word studying, perhaps those comorbid disorders like mood-related and anxiety-related disorder, other disorders, is taken care of, you may have lesser concern about SSD. And the procedure is pretty clear, right? How does it work? Well, you continuously and repeatedly confront those patients with stimuli that are related to their health anxiety. For example, documenting all diseases and not allowing them to engage in avoidance or safety behavior, which is reassurance by doctors or checking the abdomen for cancer. Now, when you talk, once again, we can talk about anxiety-related exposure therapy in a lot of detail, but what you're doing here is you're trying to challenge those clients to stay with that distress in a safer environment. In exposure therapy, use that hierarchy. What makes you most anxious? Thinking about it, checking the medical document. Well, let's do that. Let's talk about the possible condition, and the avoidance behavior or safety behavior is you're calling the doctor. Now, when you remove this behaviorally, what you're doing is sort of relearning not to avoid those situations. In exposure therapy, we ask them to, like the word says, expose to those stimuli and not seek medical assurance, not go to doctor and try to get any type of diagnosis. And that should help them to extinct, that's the process, extinct this stimulus response chain, right? You have the stimulus, but you're not responding with avoidance, and eventually you relearn and maybe be okay with some level of discomfort. and perhaps try something different, which is not avoidant behavior. And the other part that's important to keep in mind is those who are diagnosed with SSD, they try some antidepressant medication like SSRI, specific serotonin reuptake inhibitor. So let me say it again: specific serotonin reuptake inhibitor. So when people have low level of serotonin in their brain, they're more likely to experience depressive symptoms, and they try to take those medication and compare with CBT treatment. Turns out exposure therapy and cognitive behavior therapy works better, so much better than just taking medication. 45% change in their symptomatization than just taking SSRI. Well, people choose their drug. Now, can you tell? It's not a secret, right? People, especially with SSD, they would choose medication over therapy because they think it is physical condition that's bothering them, so it's preferred treatment. However, research shows that psychotherapy is more effective than medication. Now, some antidepressant like SSRI could help, and the other approach that can be used for SSD is gatekeeper physician who are assigned to limit excessive use of medical services. Before these individuals go to doctors, these people will fully examine them, if there is an actual physical condition. And if they don't receive doctor's attention, and perhaps that could be the underlying, that could be the reassurance they're looking for, which is not helping. Reduce supportive consequences of illness. That also means that family members, friends, stop providing attention. I mean, it sounds mean, and again, if there is an actual condition, definitely they need help. But keep in mind, your attention, your sympathetic talk to that person could be the contingency to continue to complain about the condition. It's very fascinating. So those are ideas that related to treatment that the research shows that could help people with somatic symptom disorder. And once you change that perception, once you change how you interpret those physical signs, there is a hope that people could overcome disorder like somatic symptom disorders and illness anxiety disorder. So I'll ask you a couple of questions, and again, I want to encourage you to look at other somatic symptom related disorders in the textbook.